Good morning, everyone. Welcome to day two of Stroudwater's 2025 Critical Access Hospital Conference. I'm Megan Hazelton, and I'll be your moderator for today's sessions. At Stroudwater, we work exclusively with rural and community hospitals from Maine to Hawaii and Alaska. Our team of former CEOs, clinicians, and financial leaders partner with hospitals across the country to improve performance, tackle today's challenges, and build a stronger future. We believe deeply in keeping care local and are proud to support the hospitals that make that possible in every corner of the country. Before we begin today, we'll just start with a few quick housekeeping items. Please use the Q&A function at the bottom of your screen to submit questions for today's presenters. We will address as many as time allows, and we'll be sending any follow-up to your questions after today's conference as well. The slides and recording of today's sessions will be shared with all registrants after the conference. Our first session this morning is Maximize Rural Health Clinic Performance, a data-driven approach, featuring speakers Kristen Norris from the Colorado Health Center and Amy Graham, Wade Gallen, and Paula Knowlton from Stroudwater Associates. With that, I'll go ahead and pass it off to Amy Graham.
Hey, thanks, Megan. I appreciate it. Welcome, everybody. Good morning. Just wanted to say we're excited to join you today to talk about this project that we had with the state of Colorado. So to share with you just a little bit about it, oh, wait, I forgot to introduce myself. I'm Amy Graham. I'm a principal with Stroudwater. My areas of focus are in the rural health clinic business as well as revenue cycle. And so I'm going to ask Paula if you'll introduce yourself and then you can hand it off to Wade.
Thanks, Amy. I'm Paula Knowlton. I'm a senior manager here at Stroudwater, and my focus is on the analytics products that we have. So we do have an RHC dashboard that we worked with Colorado to develop. Wade?
Everybody, Wade Gallen. I'm a senior consultant here at Stroudwater. My focus is on financial and operational improvement with a background in reimbursement, so cost reporting, net revenue, etc. Looking forward to being on the call.
All right. Hey, thanks, Wade and Paula, for introducing yourself. And Kristen, can you tell us a little bit about yourself, your background, your role with the state?
Yeah, thanks, Amy. I'm Kristen Morris. I'm a quality improvement specialist at Colorado Rural Health Center. We're the state office of rural health here in Colorado. Before this, I spent many years at an FQHC where I had various roles of leadership. That included me starting out in patient registration, moving on to leading a team of 30 as a community event supervisor, then helped create our population health department. And then I moved on to quality and risk manager over all service lines and our 17 clinics. In my role here at CRHC, I provide technical assistance and quality improvement to CAUSE and RHCs, mainly with our Rural Connect and our Flex programs. And one key project that I'm working on right now is this benchmarking tool that we developed in partnership with Stroudwater. And that's to help our provider-based RHCs better understand their financial picture and make informed decisions.
Yeah, we're excited to have you join us on this project because I remember when it started, it was like, hey, we really want to help support our rural health clinics within the state. And, is there a way that we can use publicly available data that's out there to pull the information in and look at it? We're establishing benchmark data that we can use going forward. And so when we started talking about it and having those discussions, it was one of the challenges was around, well, how many RHCs are out there? And well, what is the focus of the Colorado Rural Health Center? Can you share a little bit with us about, what you all were looking, what have you prioritized within the rural health clinics and what that looks like in Colorado?
Yeah,
Kristen?
so one of our key focuses is financial stability. We have 32 critical access hospitals in the state of Colorado, and 21 of them are operating in the red. So these financial challenges, they limit service expansion, and we've already seen service lines eliminated completely. And as we all know, that impacts rural communities who are already facing barriers to care. And this is driven by different things, staffing shortages, uncompensated care, and then the reliance on reimbursement from public insurance. So our goal is helping these facilities become more stable, and so they can offer that accessible care and improve the health outcomes. And creating this dashboard kind of gives us a clearer picture of what the rural health center's financial picture really looks like, and then we can go from there on tailoring our approach on how we're able to assist them.
Mm-hmm. It's, what portion of Colorado is serviced by these rural health clinics and by your cause? I mean, is it like 90% of your state, 20% of the state, or what does that look like?
So Colorado, we're pretty rural. Our state landmass is 77% rural, or frontier, which frontier meaning less than 6 people per square mile. So I like to call it rural plus. Yeah. And so we have 64 counties in total in Colorado. And out of those 64, 47 of them are rural and frontier. So 17, with the exception of just one, is located along what we call the urban corridor. And the Denver Metro is the heart of that cluster of counties. So outside of those 17 counties, outside of that urban area, we have close to 700,000 people that are potentially served by these RHCs.
Wow, that's huge. When you think of Colorado, I mean, in my background and growing up, it's like, oh, you've got these big cities of Denver, of Vail, Aspen, but then to think that you've got that large of a community that's outside of these urban metropolitan areas, and to think that even the Vales and the Aspen aren't necessarily considered that much to be urban, even though everyone knows of the name of it, right?
That's true. Yeah, Vail and Aspen, these resort cities, they are truly rural. And interestingly enough, those resort mountain communities are some of the highest public insured and uninsured populations across the state.
Wow. Yeah. And so when you look at it, how are these RHCs, those that are in the towns that we're aware of versus the ones that we're not aware of, how are they shaping the health outcomes in Colorado?
Yeah, so I think that rural health centers are they're really vital to all of these communities. They're access points, and they reduce unnecessary ER usage. They're able to manage chronic care conditions. They offer preventative care. They improve early detection. And then they're also able to build long-term relationships with patients and consider things like social and culture factors and tailor their care accordingly. What's great is with services like telehealth and expanded services like family planning, pediatrics, specialty services like physical therapy, they're able to improve access where travel is otherwise a barrier, or perhaps patients may not even be seen for these conditions. So from my perspective, they're a backbone of rural health, and they're transforming sick care into healthcare. So kind of simply put, the stronger and stabler that RHCs are, the healthier the communities are as well.
Yeah, that's a good point, because when thinking about it, I'm like, I don't want to go to the ER. I'd rather go to my doctor. But to think that in some of these communities that they've got to go to, that, I don't want to have to drive to get there either. It's like if the ER is right there, I'll go to it. But if I have a doctor that, I'm going to have to drive 30, 45 miles to, I don't know, or maybe vice versa. It's just helping to keep the focus on that well care. I think you really mentioned it earlier that you want to keep the patients out of the hospital by addressing those chronic needs and leveraging those services and everything. So, yeah,
Yeah, and I
thanks for,
think that,
oh, go ahead.
oh, sorry, I was just gonna say, I think that that's an ongoing challenge as well, right? That um, communities using the emergency room as a primary care. And that's, I think, something that's been long standing. And we're trying to implement things to kind of circumvent that. It puts a lot of pressure on the emergency rooms.
Mm-hmm.
And that's again, you have staffing shortages, you have uncompensated care for underinsured patients. And then the patients aren't getting that relationship established. And with RHCs, there's that opportunity to build those relationships and alleviate that stress from the ER. So I think we still have a long way to go with patient education on the proper use of emergency departments, but these RHCs are out there doing the work and making that transformation happen. So they're incredibly important.
Yeah. And I think about this project and what we were working on and what the value that we're providing or that we were looking to provide when setting it up. It's just giving them that data that's available to them, that the data's out there, the information exists, but helping them create a strategy for addressing this need that's in that population. What does that look like? How do we capture it? How do we bring it all together? But then be able to say, it's easier to have a strategy if you understand where you're going. When I think about, oh, Pikes Peak is, in Colorado, it's like, well, to find Pikes Peak, that's sort of a reference point that people use, to head toward. And by having this data, it's information that the rural health clinics can use to get them to that next level and really looking at that information that's there and sharing it and having that piece. So when looking at some of these metrics that we were targeting, I know that we initially started at looking for just, the all-inclusive rate with rural health clinics. They are paid that all-inclusive rate. What does that look like compared to the national limit? Are you getting paid the national limit? Are you not? Having that, but then being able to track it as a cost per visit, leveraging the data that says, what does it cost to do that? Another measure that we had initially targeted was looking at physician productivity. We had started this project prior to the legislative changes that happened in January 1st of this year, where they took that physician productivity away. And I know Wade will come back to you and talk in a minute about, what we found about, do we keep it in, do we take it out, and things like that. Or maybe we'll just come to you now and just say, what's one of the findings that you've had related to that physician productivity with the laws changing and, hey, it doesn't exist anymore, but is it really important to keep it as part of it? What have you seen?
Yeah, no, it's a great question. And I think it'll tie really nicely into our findings discussion because the way I viewed a lot of the findings we pulled out of this project was in the context of the cost report and in the context of operations. And so there may be a distinction when we look at some of these metrics between operational findings and those cost report findings. And I think for productivity, what we were able to see and hear from a lot of the hospitals that had these provider-based rural health clinics is even though the productivity standard has gone away in this year in terms of determining our payment, there's still interest in understanding how do our providers compare to that productivity amount that was set at one point in time. And so it might be more of an operational discussion as opposed to a cost report pure reimbursement opportunity. So we still are seeing a lot of those discussions take place. And so as we go through and talk more about it, there are ways to leverage data, even if it might not impact our rates right now.
Mm-hmm. Thanks for that. I think you do bring out a good point that there are metrics that we're looking at that initially started as the information is out there from a cost report perspective. Let's just pull it, put it on here. Let's look at it, purely financially related. What does that mean? How can we leverage it and things like that versus, wait, let's take a step back and create a strategy around that data and a strategy for leveraging it rather than just reactionary. Let's make sure we get the maximum benefit on a cost report, but using it as information going forward. And that really looks at, the overhead cost as a percent of total cost, tracking those costs. Do you have home office allocations? I think that it creates a conversation through that piece of it that admin costs as a percent of total cost to say to your home office, we really are important over here. I know you and I, Wade, we were just talking a little bit ago about one of the RHCs that's out there that's part of a system going, they do provide value. They may not necessarily meet the metrics of the system. However, when looking at this dashboard and comparing the information to others that are out there, you really are operating at a what's the word I'm looking help me out here. It's
Yeah.
what are we help me, Wade.
Yeah, no, I think it's a great conversation to have because you're right. We do hear often about, I guess, perceptions around the financial performance for, clinics incorporated into larger systems and hospitals. And so I think it's a very valid conversation to have and especially using this dashboard are there learnings, are there key questions we can pull out of this that can help us figure out how our clinics are performing and inform a larger discussion at the system level, and potentially even clear up maybe some misconceptions around the performance around a clinic. So I think it's a very valid point you bring up.
Yeah, it's that misconception. I think that's the word I was looking for. It's that um, sometimes when you're in a rural environment, you're unique, you look different from everyone else, all of the other clinics that are out there, that people are like, why don't you act like these people over here? And it's like, well, their situation is different from ours. We're paid at this all-inclusive rate. We're paid based on cost reimbursement. Here, we've got to have the cost so that we can get our maximum all-inclusive rate. Having those conversations and having this information out there really does, target it and allow for a healthy discussion rather than a pointing fingers at each other, but a back and forth open discussion amongst friends, but toward a common goal amongst a team. So, Paula, I know that we were out there looking at the information, with this tool. What were you seeing out there as part of it? Can you share some of the findings that you had or what you were seeing in the marketplace?
Sure. So, developing the RHC dashboard was really looking at the cost report. Obviously, we've talked about that, trending that information over 3 years. And what we found is, as we delivered this to the RHCs, they really were thankful that they were able to get their metrics all in one place, along with the comparison to other provider-based RHCs. So we were comparing them at the 25th, the 50th, and the 75th percentile. And what really resonated with me is the appreciation that they had, that we didn't just hand over the reports to them or give them access to our portal to run the reports themselves. We had a conversation with them, and Wade went through each and every metric with them and really had showed them where their findings were and where their opportunities were. So that's really something that they found was unique with Stroudwater, that we were able to offer that. And we do that with every client with the RHC dashboard.
Yeah. So I realized that I had some polls that I was supposed to fire off that I didn't do that. So let's find out a little bit about our audience and see that. And I'm thinking here are my polls. So let's launch the first one to really find out how confident are you in your understanding of the financial and operational KPIs for rural health clinics? Very confident, somewhat confident, aware, but need more guidance, or not confident at all. Give everybody a minute. Still coming in.
Looks like we've got a pretty decent mix here, but a good split between a couple of them.
Yep. It does. So I'm going to end the poll now. It looks like the split is somewhat confident of that. So it's like the majority of you are split between somewhat confident, and then the other one is aware of them but need a little more guidance. So I would say that over 60%, oh, actually, it's like over 80% of you are falling in that, with several of you in the very confident, and then others in the no confidence at all. We do have a second polling question out there, and let's go and fire that one off. So it's the questions are: does your rural health clinic currently use data or dashboard to guide decision making? With yes, consistently, occasionally, rarely, not at all are your options. All right, it looks like it's slowing down here. With this one, in looking at it, I'm going to end the poll now. It looks as if the majority of you are replying at occasionally looking at it, about 40%. And then what's nice to hear, nice to see out there, is that consistently about 30% of you are looking at dashboards and using that data to guide decision making. And then, pulling up the end is with the rarely or the not at all. So just thank you very much for participating in that. So Paula, do you want to talk through some of the elements that we picked up as part of this cost report project that we were looking in, not cost report project, this rural dashboard that we had put together?
Yeah, so we had that list of 5 elements or 5 metrics that Amy went through and talked about. But as we looked at the cost report, there were more metrics that we were able to develop, and actually the report that we provide on an individual basis for the RHC is 3 pages long. So we give you a lot of information from your cost report. It's all publicly reported data. And we give you those 3-year trending, as well as the comparison to the 25th, the 50th, and the 75th percentile. And so you're benchmarking against like RHCs, and we update this information quarterly. So we do this individual RHC dashboard. And if you go to the next slide, Amy, you'll see that we also have what we call a hospital network report. So if your hospital owns more than one RHC, and you report on your cost report each of those RHCs separately, you can get this network report of all of your RHCs in one report. So you can not only compare to the state and national median, but you'll be able to compare each of your facilities against each other as well, if that is something that you'd like to do. The next report or the next slide shows what we call our state benchmark report. And this report puts all of the RHCs in the state in one report. It is in a blinded fashion. So you get a comparison on every metric to every provider-based RHC in the state, as well as to the national median for each metric. So you're really getting a good comparison and a very large comparison, so that you really see where you are compared to the other facilities.
And I know we pulled this together because it was with the state in getting the information to Kristen and Marcy and the team there in Colorado. Can you share with us, Kristen, you've got the data, we've been reviewing it for a while now. Has it helped you in like identifying strategies going forward with working within your hospitals and their RHCs?
Yeah, so it allows us to see, I think, the diversity in each clinic and gives us a clearer picture of what their financial status is. And then it allows us to tailor support for the clinics using this data-driven information and strengthen the facilities. So when we were piloting this dashboard, we did see a trend across the clinics. And for example, that we saw some low bad debt reimbursement compared to the state and national benchmark numbers, which was a little surprising, but it allowed us to take a closer look and see why that might be. So it's, while we aren't necessarily shooting for a particular number in any given area, it does allow us to see outliers. And when we notice these outliers, it gives us the opportunity to highlight potential inefficiencies and opportunities to look into, strengthening budget planning, tracking progress, and even sharing best practices.
Yeah, it's that targeted, identification that you're talking about, to be able to say, this is where it is, here's where we are, looking for that and focusing on, this specific location may need this additional training and having that. Wade, I know we were talking about a minute ago, some of the findings that we have, because we've been on these calls with several of these clinics and having the discussions, and here are some of the learnings. Do you want to go through that with us and just share, what they've been sharing with you and some of the key takeaways that we've had related to this project?
Absolutely. Would be happy to share some of the learnings that we've had from this project. And again, I like to frame them in terms of more of the cost reporting side and the operational side when I look at these learnings. So because we developed a dashboard that was based on cost report information, it's just really important for us when we're thinking about evaluating the results that we understand that the cost report has very specific rules about what should be included and what shouldn't. And so we can pull away from the dashboard and from benchmarking these different RHCs, potentially areas where maybe there's opportunity around a cost report preparation perspective. So maybe this I would qualify as including our finding here around bad debt expenses, which you can see is in the orange box on the screen here. So when we talked with a number of these rural health clinics, or the leaders of these rural health clinics, we found that a number of them weren't reporting anything in the way of Medicare bad debt on their cost reports. Now, what could this mean? It may mean that there's nothing wrong and that everything is gravy, and it could just be that we had nothing there to claim. It could also mean maybe there's some education that would be needed on what are Medicare bad debts and should we be claiming them on our cost report. It also gave opportunity for us to compare to other providers in Colorado and see, are there some folks that are claiming these bad debts? And if so, what is distinct about them that can't be applied to other hospitals with RHCs, or maybe there are learnings that can be applied across the board here when we look at these. So that would kind of categorize as a, cost report learning from this. We learned that maybe there's opportunity from a cost report preparation standpoint for these RHCs. Similarly, we did trending, as we talked about earlier, around the all-inclusive rate, or AIR for short. That was reported. And what we kind of learned from that is we would find some unusual fluctuations in these rates according to the cost report data that we had access to for some of these hospitals with rural health clinics. And so that was a bit unusual. We kind of looked at that data and said, well, what could be causing that? Is it really, is that a true fluctuation, or maybe there was something that happened around the cost reporting side of it? And so, one of the things that we learned again pretty quickly is that there may be opportunities for education and shared learning just around how do we think about the cost report and how do we prepare it? Do we understand what makes the data inputs on the cost report different from what we might think about from an operational lens? Many of the folks that are in, the clinics and operating them might not have the best grasp on what information is reported in the cost report. And so there was a lot that we learned from that. And again, I would just emphasize shared learning and the opportunity to see, is there education here that can be provided? And then some of the other learnings that we had were more in the operational category, although they could also be in the cost report preparation category as well. Because when we look at it, we might look at, for instance, we looked at the number of visits that were reported on the cost report compared to the number of FTEs that were reported on the cost report, and said, okay, what's a general number of visits per FTE? There are nuances there as to the FTEs that are reported on the cost report, but it was interesting to look at the trending for all the hospitals with provider-based rural health clinics in Colorado, and then even at a national level, to see, what are these individual hospitals experiencing and what makes them different from all these other provider-based rural health clinics. And so maybe what we'll find there is that there's an operational opportunity. If there is a very minimal number of visits per the FTEs that were reported on the cost report, again, maybe there are questions we could ask around how that report was prepared, but it might also be a question of, well, do we have productivity challenges in our clinic? Is that something that we wrestle with? Again, focusing on that trending data, what we've learned is that those hospitals with provider-based rural health clinics have been able to benefit from looking back a few years and seeing how certain things have changed. And so, for instance, we were able to pick up and ask the questions if we saw a change maybe in the average charge per visit that we picked up using that cost report data. We were able to say, well, hey, did you have a charge master review at this point in time? And they would either confirm or maybe they wouldn't. And then we would have more questions about why was there this big fluctuation here? And so it can kind of help, again, shift the focus away from that day-to-day blocking and tackling and think about, are there opportunities in the way we operate our rural health clinic, but also how can we develop a comprehensive strategy? Is there opportunity to do this knowing where we stand compared to all of these other provider-based rural health clinics, both in the state and nationally? So I think there's a number of really interesting learnings that we had from the project, and I don't know if there's anything that you kind of add based on those discussions, but it was very fascinating to speak with many of the folks who utilized this report and gain insight.
Wade, one of the questions that we've received is, what's the biggest barrier Stroudwater has seen when encouraging RHCs to review their KPIs? And I would say, honestly, that's what's been surprising, is that we haven't had to encourage the Colorado. I mean, we were chatting about it backstage a minute ago about they are active in this. They're excited to have the data. They're excited to be able to make decisions. And then as we've had conversations, some of the things that we've looked at in that 3 pages worth of data that Paula says is included in this report, we look and we're like, well, you have nurse practitioners or PAs identified this year, but you didn't have it for the prior 2. And they're like, oh, yes, because we hired a nurse practitioner. Or it's, no, we've had this person all along. They've been here for 10 years, identifying gaps in that. And I think from my perspective and looking at it from a holistic or even from revenue cycle, because we're always looking back upstream when we're dealing with those challenges,
Yeah.
it's that how what we do impacts that entire picture. And by looking at this dashboard with the comparative elements and things like that, that we can go back multiple years, look at the data, see what's changing, and go, was there an operational change that caused this to happen? Or did we do a reporting change, a system change, and we've missed something in that transition? A lot of people went to new EHR systems between 2020 and 2023. And so, are you capturing all of that data that you should have been capturing before, you were capturing before? Can you capture that now and bring that forward? And I really, see that we haven't had a challenge with talking people, or,
Yeah.
they're more like, wow, I like this, I'm going to do it. And, talking to people about that. And I would say,
Yeah.
we are coming up, but we've got 5 minutes left. If just want before we start the next session, just want to be cognizant of everyone's time. If you do have questions, you can put them in the Q&A section for us. But as we're waiting for those questions to come through, we will be answering them afterwards if we can't answer all of them live due to our time constraints. Is there anything, just in final words, Paula, that, I'll go to each of you, Paula, Kristen, and Wade. Start with you, Paula. What, any final words about this dashboard and the tool that we've been able to provide?
I would just say that it's been very well received with the clinics that we've reviewed it with. So if it's something of interest to you, just let us know. We're happy to demo it for anyone.
Mm-hmm. And pulling that information up. Kristen, what
Yeah.
about for you? What have you seen with the state?
Yeah, just to echo what's already been said, our provider-based clinics have been really excited about this tool. To my understanding, there hasn't been anything like it before now to be able to compare state or national. So positive feedback, and again, we want to provide our RHCs with all of the tools and the best data to help them make informed decisions and take that closer look about what can we possibly do operationally, or what can we look at a little bit closer to strengthening our financial health. So we are really happy and pleased to be able to create this dashboard in partnership with Stroudwater. And I can't wait to see it expand and how it can potentially help RHCs across the state and hopefully across the nation.
Yep. Wade, what about for you?
Yeah, I mean, I think the thing that really gets me jazzed about this is it provides an opportunity for the in a realm of cost reporting to interact with the realm of operations and to be a platform for questions and shared learning, which I think is so crucial. And I think is part of the reason why it's been successful is because it provides that opportunity for shared education, for shared learning, sharing of best practices, et cetera.
Yeah. And, I know that one of the things that we see some questions coming in, around, what are we substituting as a metrics now that productivity standard is no longer in effect? And then also any thought of using work RVUs as a measure of provider productivity. For both of those answers, I would say that's what's so fun about this project that we've been working on. It's like, oh, this has gone away. Well, we're still leaving it in there because here's the relevance of using that. Because in having those conversations, you still want to hold your providers to a product. You know, some locations may still want to hold their providers to a productivity standard. But then thinking about new elements when answering the question about our RVUs as a measure of provider productivity. Oh, that's cool. Let's look at how we can incorporate that data in. When we started with this, we were using publicly available data. And so if we know of a way to pull that in, or looking at expanding that to say, if you as a clinic have that information and you want us to track that as part of the project itself, that's something that we're open to. And, you know, really looking at the iterations of it, but just having data available and the flexibility of it, I think has been just very enjoyable and exciting, and as Wade said, jazzed about this project. So with that, I do believe we are at time. So Megan, I'm going to turn it back over to you. Thank you everybody just for giving us time on your calendar today. We do appreciate that, and we'll jump over to the next webinar now.
Thank you, Amy, Kristen, Paula, and Wade for your presentation. A lot of great information. You all do have some questions here that we weren't able to get to. If your question was not answered, then we will be following up with you all via email, and you should receive the answers to all questions asked during this webinar.